Well, we're going to talk about everything you always wanted to know about fetal arrhythmias, but were afraid to ask, all in 30 minutes. And I keep showing this slide. It's actually relevant in this talk because Nuvo is a company in Israel that I'm involved with. Jack is also involved, and it may have some products related to fetal arrhythmias. I'm not going to talk about that product, but in the interest of full disclosure, because I'm also on the Yale Conflict of Interest Committee, and I don't want to get reported for failing to disclose, that's my disclosure. So lots of different things to talk about with arrhythmias, and the stuff that's most common is probably also the least important. Most common being the irregular fetal heartbeat, but it might be important. Don't just dismiss it. We'll talk about tachycardias and fixed bradycardias. Not going to talk about electronic fetal heart rate monitoring and fetal bradycardias in labor. We'll leave that out of this conversation. The distribution of arrhythmias that we see is very much skewed towards the isolated extrasystoles. And while this data is now 20 plus years old, the fact is the distribution, if anything, is even more skewed because in the time that Charlie Kleiman and I collected this data, there weren't a lot of people treating fetal arrhythmias in New England and upstate New York, and now there are a lot. So we don't see many referrals anymore. The stuff that we see now comes mainly from our own population or the hospitals that Yale New Haven health system includes. We're going to start by talking about the common, and that's the premature atrial contractions, which we can see happening right there is a premature atrial beat that you only see the one signal. You don't see the E and the A wave. You only see the A wave, the active atrial systole. And I'm going to take that off because it's flashing. The question with these, because they're common and they're scary to the parents, is how often do they represent something significant? How often do they represent neonatal arrhythmias? And do they signify the presence of other cardiac problems? Now, has anybody here seen a family with a fetal arrhythmia that wasn't scared? No, we all see them and they're scared. They think the baby's heart stopped, right? That's the first thing I tell them is your baby's heart didn't stop, because they think it stopped and restarted. That heart rate that's going every half second, so 500 milliseconds, if it takes 750 milliseconds for the next heartbeat to be heard, it sounds like eternity to the parents. And that's what they're hanging on, right? The big thing, they're going to go to their prenatal visit and they're going to hear the baby's heartbeat. So how often do these really represent a problem? Well, let's just take a moment to talk about what they look like. This is my favored way. I don't like M mode very much. I like Doppler. I like to be able to see the E and the A waves. And you saw in that other picture the early A wave that represented a premature atrial beat. Now, this study that we did is still the largest that I know about on fetal arrhythmias. We had 595 patients that we reviewed who were all referred for an arrhythmia, another highly scientific entry point. Somebody's secretary called my front desk and said the baby's heartbeat sounds irregular. That was the entry criteria for the study. So somebody ticked off the reason for the echo was fetal arrhythmia. There were about another 20 patients that we found premature atrial beats when they were having fetal echoes for some other reason. So those show up in some of the data that I'm going to show you. So 595 sent in because of an arrhythmia, and we only found an arrhythmia in a minority of them, right? In about 44% to 45%. The other 55%, we couldn't find an arrhythmia. And part of the reason we'll talk about to do a fetal echo is just to watch the heart for a long time and make sure there's nothing bad going on. So in our watching, we didn't see anything in over half. There was almost all premature atrial beats in the remainder. There were 10 that had significant arrhythmias. So between 1% and 2% of the patients that are sent in for an irregular heartbeat have something that you really do want to know about. And that breaks down as, before I get to that, there were 2 that had structural heart disease in the 614. Now that includes the 20 or so that we found during a fetal echo. 2 had structural heart disease. That's 0.3%, which the 95% confidence interval on that certainly does not go above the rate that you'd expect in the general population for structural heart disease. So let me say that in a positive way. I think there's a very good argument to be made from these data that there is no increase in the risk of structural heart disease. The two that had structural heart disease, one had supraventricular tachycardia and an overriding aorta. Not sure whether that was coincidence or not. And another had second-degree heart block and corrected transposition, a known association. There were two neonates that had trivial VSDs that were found, but those resolved spontaneously, so I didn't count those in the numbers. Of the 10 that had significant arrhythmias, there were the two here, the ones with structural heart disease. There were 5 that had supraventricular tachycardia, 2 had atrial flutter, 1 had a ventricular tachycardia. So 10 had the stuff that we really do want to know about in fetuses, because all of those require some intervention. It may be observation, it may be delivery, it may be medication, but all of those require us to really be paying attention to the fetus. And we didn't have complete follow-up, but had follow-up on about half because they delivered either at Yale or in the immediate vicinity, so we knew that the babies would have come to us. And there were 5 postnatal arrhythmias, 3 were Wolff-Parkinson-White, 2 on postnatal day 1, 1 at age 4 years. I don't feel bad about missing that. And then the other 2 shown there. All of those were in the extrasystole group. So we didn't find anything in the 55% that had sinus rhythm the whole time that we watched them. Again, arguing to me that we don't need much follow-up on the patients that have a regular heart rate when they come in. Whatever was going on either is so rare that we didn't see it or has already resolved. So the management for these kids, to me, is still to do a fetal echo, because I want that time looking at the heart. If there is an irregular heartbeat, we tell them to avoid caffeine. It might increase the rate, not the rate, let me say that differently. It might increase the frequency of seeing the irregularity and make them more anxious. We recommend that they go for weekly auscultation. I don't do NSTs. I tell them, go to your OB office and have them listen. If the heart rate sounds faster, if it's over 200, then we'll get you back in immediately, day or night. But eventually, they're going to stop hearing an arrhythmia and then go back to routine prenatal care. If there's no arrhythmia found, we don't do any follow-up. The alternative to the fetal echo would be to do a monitoring session for 30 to 60 minutes, so the equivalent of watching the heart during a fetal echo. 2 problems with that. One is, the biggest one is that a quarter of the patients are below 24 weeks. Is there any obstetrician in the room who would like to ask their nurses to do fetal monitoring below 24 weeks? No takers? No. You know, it's the finding a mosquito with a flashlight problem. The baby's moving around too much. They're not going to be able to do it continuously. And the other caveat is someone needs to be in the room listening during that monitoring session. Because if the baby is having a couple of second run of tachycardia, the internal logic of the machine may skip over it. It may not show up. And I've seen patients go from a single run of 5 seconds to incessant tachycardia inside of a week, and actually that one went on ultimately to a fetal demise. So it can get bad fast. You want to know about it. Somebody has to be listening, not just putting the patient in a room, come back in a half hour and check the tracing. So no follow-up for no arrhythmia, weekly auscultation for those with PACs. All right, the stuff people are really interested in this talk is the SVT, the tachycardias, I should say, and the bradycardias. So let's talk about tachycardias. I get really nervous when I give this talk in front of cardiologists, I have to say, because I do things like pull pictures that I'm pretty sure I understand from New England Journal of Medicine to demonstrate that there are many ways to have a fetal tachycardia, depending on where the cycle of electrical energy is circulating. So if it's circulating just in the atrium, you tend to get a really fast rate. You tend to get atrial flutter. That may have variable rates in the ventricle. if there is conduction through an accessory pathway, so the normal conduction from the sinoatrial node through the bundle of His into the ventricles, if there's an accessory pathway, a short circuit, somewhere between the ventricle and the atrium, the electrical energy can re-enter the atrium, and if it's at just the right time, it can set up a cycle of recurring rapid heartbeat. If it's going retrograde from the ventricle to the atrium, that's the more common thing that we see. If it's going antegrade through that accessory conducting pathway, that's Wolff-Parkinson-White syndrome. How am I doing, cardiologists? All right so far? Good. I'm not going to try to interpret the EKGs down at the bottom, but we don't use EKGs in the fetus, so it's all right. The typical heart rate for the reentrant tachycardias is 240, give or take 15 or 20 beats. So this is a typical case. This actually, I think I may have been here talking to Alfred's course a number of years ago when one of my faculty colleagues was at one of our community hospitals and texted me this picture of a fetus with a heart rate of 250. Hallmarks of this is there's one-to-one atrioventricular conduction, and again, rate in the low to mid 200s typically. So we can see that here. We've got another hallmark of these is they are often precipitated by a premature beat. So in this part, the heart rate is normal. We've got our M mode line running through the left ventricle, the right ventricle, and then the back of the right atrium. And we can see the very rapid atrial rate. We can see there's one-to-one conduction, 227 beats per minute. And remember that I didn't stretch out this signal as much as I might have, but remember, very tiny movements of that cursor are going to have a big impact on the heart rate when it's that fast. Typically with atrial flutter, it just looks like it's moving too fast to count in the atrium. Down at the bottom here is the atrium. And this one has 2-to-1 block. I believe. The next one shows the 2-to-1 block better. This one looks like it's 1-to-1. This one shows 2-to-1 block, and we took the atrial rate is 441, the ventricular rate 246. So I must those are separate pictures because I had the atrial and ventricular rates better in different pictures. But roughly, it's a 2-to-1 block that you see, and it may be 3-to-1 or 4-to-1. There are all sorts of rates that you can see. Here's another one that has a differential rate. The atrium's going much faster than the ventricle. The physiology of these kids gets really interesting because when the heart's going that fast, it's not pumping properly, mainly because it's not filling properly. Remember that the fetal heart is very dependent on the atrial contraction to fill. Fetal myocardium is stiff, it doesn't relax well, and it needs the atrial contraction, which is why in a normal heart, the A wave is higher than the E wave, and the area under the A wave is higher. There's more blood flowing into the ventricle during active atrial contraction. That's different than adults, because we mostly fill passively, and it gradually shifts in the course of pregnancy. Later in pregnancy, the E to A ratio tends to be much closer to unity. Whereas this is the same fetus on the top and the bottom in sinus rhythm and in a period of tachycardia, and you can see that the A wave is really small. So the fetus is no longer able to use the atrial contraction to fill the ventricle properly. And if you look in the inferior vena cava, this is the same fetus in a period of sinus rhythm and in a period of tachycardia, and you can see that it's all forward flow. You can get a little bit of reversal of flow in the inferior vena cava, but during the period of tachycardia, we see a lot of reversal of flow in the vena cava. Same thing shown here. This is a fetus with a retrograde IVC flow during tachycardia and forward flow with a premature beat during the period of normal sinus rhythm. This is a human fetus. This is a sheep fetus. I talked yesterday about London, Ontario. This was an experiment done by Carl Nimrod in London, Ontario. And they took sheep and paced them to tachycardia. So we see flow in the inferior vena cava during sinus rhythm, and then paced to tachycardia, and it looks just like the human fetus. And then when the fetuses actually developed hydrops within about 6 hours of pacing. And then when they stopped the tachycardia, they saw actually an enhanced, this is right after the pacing was discontinued, this is a few hours later, and they saw enhanced flow as the fetus was clearing edema, more flow in the inferior vena cava. So one of the things that may cause these fetuses to get hydrops may just be increased venous pressure. Now, I'm not going to tell you how to treat fetal SVT. I'm not going to give you a recipe, a cookbook, because there isn't one. And the key things are to be sure you know the diagnosis, because the treatment of atrial flutter is different than reentrant tachycardia. If you have a way of telling that it's Wolff-Parkinson-White, the treatment is different for that than for retrograde tachycardia. You have to talk to your local cardiologist and electrophysiologist, and often we have the adult electrophysiologists involved, because we have to be really careful with these medications. Anything that can stop an arrhythmia can cause one, should be our rule. So we don't want to throw around medications, and these drugs all interact with each other. It drives me crazy to see somebody who's not familiar with this, who's trying to treat a fetus, and they're changing medications every day or two. You can't do that. You have to allow enough time for the fetus to get the drug. It can take several days for digoxin, for example. And you have to allow enough time to clear the drug if you're stopping it. Now, I hate amiodarone because of what it does to the fetal thyroid. But it's people talk about using it a lot for the fetus. Anyone know the half-life of amiodarone? Anyone know what it's measured in? Seconds, minutes? Stop me when I get to the right answer. Hours, days, weeks, months. Nobody wants to stop me. Years? No, I think it's 54 days is the half-life. Okay, so if you give that to the mom, that's going to be floating around and affecting the other drugs for a long time. And I think what I've learned, certainly, is that there is a role for careful observation, particularly as you get into the third trimester and you're thinking about how quickly you can get steroids and deliver the baby. Closer it is to 39 weeks, the easier it is to treat these kids, because delivery becomes more and more an option. And I said before, there was one that went from 5 seconds to hydrops inside of a week. I've seen that, but more often what you'll see, if you can get them in the hospital and monitor them for a day, is that they have patterns, and you'll see that they're in the tachycardia only a minority of the time, or they're in it 90% of the time, or some other pattern, and that can help drive the decision for treatment. If it's 23 weeks and the fetus is in tachycardia 90% of the time, yeah, we have to talk about treatment. We want to get something on board that's going to get this under control. If, as I said, it's 38 weeks, it's easy. You know, we should deliver the baby. And that's why you need the team approach, with everybody putting in their opinions and, of course, shared decision-making with the family. Now, I want to show, for tachycardia and bradycardia, I have 2 fun labor and delivery stories. This is a patient who was on our labor floor, and the obstetrician came to my office, which used to be down the hall from the labor floor, and said, I have a fetus down there in labor, and I think there's SVT. So I went over and did a scan, and the fetal heart rate was in the low 200s. And I said, how dilated is she? She was 4 centimeters. I said, you're going to think I'm crazy, but I want you to rupture her membranes and then have her get up and walk around. I want oligohydramnios, because all the obstetricians know what happens with oligohydramnios. What do kids do when there's oligo and they contract? They get bradycardias, right? They get vagal response. How do you treat a non-fetus with a tachycardia? Well, one option is vagal stimulation. So we tried it, and you can see what happened. She had a bradycardia, came back into sinus rhythm. Now, it didn't work perfectly, because she went in and out, but there was enough time with, I think the time that wasn't tachycardia was clearly what we call a category 1 tracing. There was enough time that she was able to have a vaginal delivery. And one other tip to tell families when you're counseling about this is that the biggest cold shock of your life, which is a vagal stimulant, it's like putting someone's foot in ice water to try and break a tachycardia, the biggest cold shock of your life is going from a 99.6 degree uterus to a 70 degree delivery room and you're soaking wet. So we've seen kids that have the tachycardia up to the point of birth and then they break. Now usually they go back into it in the newborn nursery after a little while, but I always warn the parents, baby might not have it immediately after birth, but we're going to do EKG and monitoring and check it out. Okay, on to bradycardias. And yeah, you don't need a fetal echo to know that heart's going too slow. And this is what it can look like on the Doppler. We have the atrial filling up top, and we can see it's going along, and the ventricle is going along at its own merry rate that's totally unrelated to when there are atrial systoles. There's going to be a breakdown. Some of the kids that you see with bradycardias are going to have structural heart disease, and we've talked about that in several of the talks already this weekend. Usually complex lesions, but it can be an atrioventricular septal defect, corrected transposition, the heterotaxies, all the things we've been talking about. And roughly half will be immunologic. The anti-SSA or Rho antibodies and SSB or LA antibodies are associated primarily with Sjogren's syndrome, but basically in rheumatologic diseases, as far as I can tell, there are very few rules, and there's a lot of overlap between the syndromes, and it doesn't have to be Sjogren's syndrome that the mother's presenting with. Those kids rarely have structural heart disease. We're going to talk a little bit about hydroxychloroquine. We're not talking about COVID now. We're talking about heart block and other possible treatments. Titers are important if they're done in the right lab. There are lots of commercial labs out there, lots of hospital labs, and there's a lot of variation between labs. So we're doing this because we're part of a study, but using a reference lab is really, I think, a good idea to be sure you understand what's going on with the patient. And higher titers definitely relate to the risk of disease if it's done in one of these reference labs. We use Joe Byon's lab at NYU. Heart block is frequently associated with hydrops. If there's structural heart disease, heart block, and hydrops, it's basically deadly. I don't know that fetuses or neonates are able to come back from that because their lungs are full of fluid and their bodies are full of fluid, and it's very hard to resuscitate those babies. With an immunologic cause, it may be treatable or it may be transient. It may be an initial shock response to the bradycardia that's then followed by some recovery, because the fetal heart does have some level of Frank-Starling relationship. It's able to respond to filling with better contractility. So jury's out on that. I mentioned before the antibodies can be seen with a lot of different rheumatologic diseases, and this just shows the distribution of finding these antibodies with different connective tissue diseases. So basically, when we have any connective tissue disease, we want to be sure we know about the patient's Rho and LA status. Now, there are several different categories of people that are going to present to you with antibodies. There are the people who are known to have a rheumatologic disease. There are people who don't have a rheumatologic disease but have had a prior child with heart block or neonatal lupus rash. And there are people who had some joint pain and maybe a miscarriage, and their doctor checked off every box on the rheumatologic lab slip, and they come back with these antibodies. And these are different populations, particularly the ones who are incidentally found to have antibodies with no rheumatologic disease, have a very low risk of a baby with heart block. This is a meta-analysis of almost 700 women, and a lot of them developed rheumatologic diseases later in life. This is data from Jill Byon's database at NYU, and shows that women who've had a prior child with heart block and also neonatal lupus rash. About between 15 and 20% have heart block in another pregnancy. Whereas the women, it's not on this slide, but the women who don't have a prior affected child have about a 2% risk. So very, very different levels of risk between women who've had a prior child that's affected and women who haven't. About 70% of fetuses with heart block will present before 24 weeks of pregnancy. Some present later. And it's tempting to say, well, people just weren't listening or they didn't pay attention. But some were in our studies, and the studies that I've been involved with, along with Joe Byon's team, some were in the studies and having regular fetal echoes and things and presented late. So it can happen later in pregnancy. But the majority happen before 24 weeks, and that's the time that we tend to do our most intensive surveillance, is 17 to 24 weeks. My own theory is before 17 weeks, the fetal immune system just isn't revved up enough to respond, so we don't see it much before 17 weeks, but after that we can see response. The first treatment report was from us at Yale in 1995, and we had 5 cases where we gave steroids and we thought they helped, but it's been controversial. There's studies going both ways on whether steroids help. In fetuses that have complete heart block, steroids probably don't help at all. And so if we start them too late, they're not going to show a benefit. The question is really, can we find them early enough that a treatment might help? Other treatments that have been recommended include using beta mimetics. I don't think those help. They can change the heart rate, certainly, but atrioventricular contraction sequence is critical in fetuses. And these fetuses also have a myocarditis. They tend to have very echogenic myocardium that is from the myocarditis. And unless we're treating that inflammation, we're not going to improve their condition. So that's why I like steroids. Other people use plasmapheresis has been used. That can be very challenging for the patient, and intravenous immunoglobulin is also being used. So for early diagnosis, what we've used has been the mechanical PR interval, and it assumes that the A wave that we see in the fetal echocardiogram and Doppler, it corresponds to the P wave on an EKG, and that the ventricular systole is due to a QRS complex on an EKG. So we can measure the time from the onset of the A wave to the onset of systole and have something that should statistically relate to the actual PR interval. And it relates pretty well. It's not the exact same number, but we don't need the same number. We need something that's reliably going to have the same relationship. And the normal is between 110 and 140 milliseconds in the second and third trimester, pretty stable throughout that time. So the question is, can we identify early heart block? This is the way it looks on a Doppler. So we've got the E wave shown there, and then the onset of the A wave is shown in the notch. That's the point to measure. And then the onset of systole is shown there with the ventricular contraction. And we measure, you can see there's a little plus there. I'll go back one. Little plus right there, and the line right there showing our measurement. And I overlay a little EKG, and we have 115 milliseconds. This is a patient with a previous child with heart block, and it's totally normal. So here we are. This was at 18 weeks. Same picture, 115 milliseconds. She was in our surveillance study, and we had talked about if we see anything, we'll randomize you to steroids. This is a week later. I don't think you need to take a measurement to see that there's a really long gap there, right? And in fact, it was 165 milliseconds. We offered her the chance to be in a randomized trial. She threatened to kill me if she didn't get steroids, so we said that's no consent, and we gave her the steroids and she got better. Hydroxychloroquine And that baby was fine. Her first baby's had a lot of problems. Hydroxychloroquine definitely has been shown now to reduce the frequency of developing heart block in fetuses at risk. So we recommend that. I think most rheumatologists give it routinely now to women who have Roux-en-Y antibodies who are considering pregnancy. And this paper from 2020 is where the data for that's found. The stop block study is going on now. Some people here are probably recruiting for it. If you have questions or patients, we can help you get them enrolled. It's weekly echoes and home monitoring. They do home monitoring 3 times a day. Everything gets transmitted to Bettina Cuneo, who's the stop block doc, which I can't say repeatedly. And she checks all of these. If there's an arrhythmia, all the study centers agree to do a fetal echo within 6 hours and to get the patient steroids and IVIG. That we're still recruiting patients into the study. We have several hundred right now. So we might be able to do something with DEX or with other medications. It can be a really short time from when the fetuses start to show signs, from when they're normal to when they start to show signs. Look for tricuspid regurgitation and atrial echo densities as other signs of impending injury. Third-degree block, I think the game's over. So we need a good way to find a good, meaning safe and economical way to find these kids early and then prove that treatment helps. And I, again, recommend hydroxychloroquine. Last quick labor vignette, a patient with complete heart block, and one of our nurses said, "Let me try to monitor her." I said, "You're crazy." She said, "No, let me try." She tried, and for about 3 weeks before she went into labor, we were able to do external monitoring. They were able to get an atrial rate. So she came in labor, and her obstetrician, without consulting MFM, unfortunately, decided that there was a very ominous late deceleration right there. And what do you do for late decelerations? You rupture membranes and put a clip on. Well, not with fetal heart block, because what you find is a bradycardia, because now you're measuring the ventricular rate, and this poor woman had a stat section. And fortunately, the baby's okay, but could have been avoided. So that's my last vignette. Thank you very much for your attention.